So we
Yeah,
can start.
yeah.
We'll just start. So hello everyone. Welcome to our fireside chat on breaking the ice about fertility treatments. I'm Anupriya Kapur, and we will be discussing various fertility services, the stigma surrounding them, and sharing experiences to help normalize these discussions. We have with us Dr. Smitha. Thank you so much for joining us. An expert in gynecology, over 13 years of experience. She specializes in high-risk pregnancies, fetal medicine, and endocrine disorders. Hello, Dr. Smitha.
Hi, Anupriya. That was nice. Yeah, nice to catch up on you all on such a important discussion. I'm sure it's going to be great.
Yeah. So let's begin without wasting any time at all. So throughout our lives, in our 20s and 30s, doctor, women are told how to not get pregnant. We assume that when we are ready, when we decide, it will happen quickly and automatically. It will be like a natural thing. However, for many of us in today's world, that's not the case. And we are finding ourselves waiting for a year or more without success before seeking any help. So today we want to discuss this a little further. And the first thing I wanted to discuss was that what are the benefits of seeing a specialist earlier rather than later?
Very true, Anupriya. I think this is some problem which most of the people face. We all think it's very easy to conceive, but on the contrary, that's a tougher job. It's easy to give contraception, but it's difficult to make someone conceive. I think that is where the role for an earlier connect with a specialist comes in. And I think everybody, irrespective of their timelines or individual timelines, late 20s is when I would suggest mid to late 20s is when you find in your window to meet a specialist, draw a frame line, because Google does give us a lot of information, but you need to customize it on to individual basis, like, what are your requirements, and then take things forward. So I think it's very essential that you make this contact with your specialist between 25 to 29. I wouldn't even say 30, 25 to 29, because a lot of vital information can be obtained. You can draw your own personal timelines with the specialist, and all this can be done without pressure on you, because you can have this consult later on also in your 30s, but then there'll be a lot of pressure on you as to what if something happens, what if my reserve is low, or what if things are too late and things are out of my hands. So knowing the information, being planned for it and prepared for it, and prioritizing things as per your requirements, I think that's very essential, and that's where the role of meeting a specialist comes in.
So I was thinking we'll just sure. I was just thinking we can break this down a little further, specific to the
Yeah,
age category or groups. Say, for example, women who are in their early 30s. So nowadays, women are as career oriented, and
yeah,
we are also getting married a little later than usual. It used to be earlier, early 20s. Now it's early 30s mostly. So
yeah.
what option should we consider as women in early 30s when planning the fertility journey?
Yeah, women in early 30s, I wouldn't say anything much different, but yeah, as soon as you do plan for conception or you're thinking about conceiving, do meet a specialist so that you are aware, you're guided as to. I see a lot of couples who come in and they say, like, probably we missed out on this window where we could have done things better, we could have planned things, because I see a lot of more couples wanting to try things the natural way, and they're very clear, like, we do not want to go for it if it is going to be an IVF pregnancy. We do not want to go that way. So they're pretty clear. And when you're so clear that you want to take it up, in the natural way, and it's very important that as soon as you think about uh, planning for conception, or in fact, I would say once you choose upon your partner, just like how you would share a mutual conversation about, prioritizing your profession versus your family and drawing timelines, that is the time you need to plan things. Yeah.
So that brings me to the next question, which is absolutely related to this.
Yeah.
What are some of the other options which are less invasive and more affordable or alternatives to IVF? Because, now what happens is when we try, if it doesn't happen, we panic and we're like, okay, let's go for the IVF, or let's start finding out egg freezing and, freezing of embryos. Let's try IVF way. But we have other options. So if you could shed some light on that.
Yeah, see, this is another reason why I would emphasize or re-emphasize on meeting the specialist much early, because then your bandwidth of choices are a lot more. Because you could even start from, if you have a regular cycle, and if you're aware of the fertile period, and if the baseline workup for both the partners is done, I would insist there should be a baseline workup done for both the partners, because only after that would we know that yes, things are going looking good and you could take it up the natural way.
What would
Yeah.
base work mean?
Yeah,
Sorry,
the
it's
base
too technical for me.
Yeah, sorry. So the baseline workup for any fertility concern would be for both the partners. Unlike earlier, people would presume that it's the woman who is responsible for all the, baggage of carrying the infertility taboo. It's both the partners, which we are all aware these days. So it's very essential, but that both are worked up for any major, fertility barriers. Like, a woman may not be ovulating, so it's very essential that we document that that she's ovulating, even though if she's having regular cycle she may not be ovulating. So the common myth is that I'm having my periods pretty regularly every 28, 30 days and I'm sure I'm ovulating, because that is not the truth all the time. So it's very essential that we document one follicular scan. It could just mean a scan in the mid cycle to see that the egg is ovulating, so we are sure that the woman is ovulating. And you also get the idea that around 13th day, if she's ovulating, we know that next cycle she could try on her own around the 13th day. It's not necessary that every month we go about doing these scans. So basically, being aware of your fertile period, knowing when you ovulate, these are part of the baseline workup. No major hormonal imbalances like your thyroid or endocrine disorders, knowing your baseline sugars. The genetic tendency for Indians is so high that most of the women and men are caught unaware about them being diabetic, because their parents or grandparents got it in their late 50s or late 60s. But nowadays, in view of the changing lifestyle and stress and diet, people are getting diabetic much earlier. So it's very essential to rule out diabetes, thyroid disorders, and all these as the basic workup for both the partners, and nutritional deficiencies like vitamin D deficiency, which is very common. And with a lot of the people choosing in for vegan options and vegetarian options, B12 deficiency is also on the rise. So all these things need to be corrected, and these form a part of the basic baseline workup for fertility. And for the male partner, definitely it is going to be the semen analysis. I do insist on my couples that the male partner evaluation is very important. I do give them a bandwidth of time, take your time, because men do get apprehensive and they're under stress when you tell them to go in for testing. So I do tell them, see, find your comfortable window, take a month or two, no harm, and then get your semen analysis. But you need to get it done, is what I emphasize. So they're more comfortable when you give them timelines, and that is the reason that instead of randomly trying for 3 to 6 months naturally and then ending up testing yourself and then having some problems, it is very easier to go, like the in like we evaluate first, rule out the basic problems, major concerns, and then let you try naturally. So I think this is a more controlled manner of knowing where you're heading. Yeah.
And
So
are there
yeah, like
anything apart from IVF that can be done?
yeah, there are a lot of options. You would have recently heard about this home IUI option, self
Yes.
IUI or home IUI. I think this is the next step to monitoring your follicles. This, though I'm not a great believer of it, because in IUI we typically do the intrauterine insemination, but in these devices, I think only one of them is FDA approved, and we do have a lot of other devices which have come into the Indian market as well. But it does help in couples where they may not have sufficient time to time their intercourse, or they may not be in the right framework because of the stress and other things. And it does help to a certain extent. It's going to be intravaginal, it's not going to be intracervical, because it is not under vision, so it's a blind procedure. But it does help compared to the conventional method of trying. It does help to a certain extent based on the kind of problems the couples have. But I would again reiterate that it may not be helpful in certain situations of male factor, like if their semen parameters are abnormal, then you cannot choose it over the conventional IUI. IUI is the next option. That is the intrauterine insemination, where the semen of the male partner is artificially injected into the woman's cervix. So this is into through the cervix into the uterus. So this is one step ahead, wherein, if you suspect that there is a low sperm count or low motility, so you're bypassing the truth and directly injecting the sperms inside. So that way, the chances for fertility are higher. But you will be surprised when I tell you the percentage of success rates in these, because ultimately it boils down to numbers. IUI or intrauterine insemination is only 20%, 15 to 20%. So you would understand how strong natural conception is. I mean, the chances of conceiving in your own natural method. IVF is what we all know. So in this, like we all know, the oocytes are retrieved from the woman's ovaries, and the sperms are made to fertilize the oocytes in an artificial environment. And then they're frozen for some time, and then after a couple of months or 3 to 6 months, whenever you choose to get pregnant, that is the time they can be artificially transferred. That is the embryo transfer technique. This is a conventional IVF, and in this the success rates are only 30 to 40%. So though some centers may claim 70%, 60%, overall worldwide recognized is only 30 to 40%. So again, I would say that, it's nothing can beat nature, nothing can beat the natural trial and natural conception, provided the major problems on both sides are ruled out. So these are the things. And in the baseline workup, I would also insist for the woman that in spite of trying for 3 to 6 months, if they are finding difficulty to conceive, the tubal factor evaluation is very important. So we all know that the egg and the sperm meet each other in the tubes of the fallopian tubes. So basically, if there's a block anywhere, so we describe it as a blockage in the road. So if the road is blocked and the egg and the sperm are not able to meet, then there's no fertilization happening. So this can be evaluated through an X-ray test or the HSG, which is again a part of the extended workup, not the basic workup, but an extended workup for a timeline of 3 to 6 months. Yeah.
So,
So this was,
if I was to take away, is it
yeah,
safe to say that, earlier they used to say you should have your annual checkups once you're 35, right? Would you
yeah.
say that we should have our annual checkups now when you're 25 onwards, like, just so that you know your baseline, your, like you said, your vitamins, your minerals, your deficiencies,
Absolutely,
your
absolutely.
hemoglobin.
Yeah, absolutely. And I would say around more than 50 to 60% of our patients are doing it annually from the age of 25.
Right.
Yeah,
And safe to say that because the kind of environment we are in, that smoking should be
yeah.
completely out, and maybe drinking very, very moderately, if we want to, conceive naturally. Would you say that? Dr. Smitha's screen is frozen.
I'll just check 1 minute.
Yeah, yeah,
Sorry, Anupriya, I think I lost you for a minute. I don't know if the rest
yeah.
of them could get you, or is it my
Yeah.
connectivity issue?
So my point was actually not even a question. I feel that smoking is a big no in
Absolutely.
today's day and age. And even though we have examples, like I know people who used to smoke and have conceived and have natural birth, but life used to be very different earlier. I think we lost you again, Dr. Smitha. Ranjini, can you check?
Yeah, I'm there.
Yeah.
Yeah.
Okay.
Yeah.
And drinking also very moderately for both the partners. Usually, like it again comes down on the
Yes.
woman, but it should actually be very moderately for both the partners.
Yes, I think they're pretty aware of these facts, and people do come to me and they'll be like, "What's the average time that I need to, keep myself away from these before I start trying to conceive?" So, I mean, I think couples are much more aware and they do understand. So, and I do give them that 3 months time bandwidth where they can wean themselves off from what they've been, habituated to, and cut it down. And I do tell them like going for more social drinking and not, overdoing things on a single day. So, yeah.
One thing like PCOS, PCOD, okay? Now, women who have PCOS face unique challenges. So, what specific treatments and steps should they consider to manage their fertility better?
Yes. So women with PCOS are very unique because they have a lot of concerns. One would be, the first one would be irregular cycles. Definitely, they wouldn't be aware of this fertile period, and they wouldn't be aware whether they're ovulating on a particular cycle or not. So all the rules that I did mention about the pre-workup and other things do not hold good for PCOS. And the third thing which adds to the diagnostic dilemma is the AMH values. So we go by this test called AMH, which predicts your ovarian aging basically, or your egg reserve. So AMH levels are generally between 2.5 to 4.5 in an average. So any value which is lower is considered as a lower reserve. So basically, any number below one is something like, you need to take immediate action. So any value more than 4.5 is also not taken as a good thing, because that indicates PCOD. So people
Okay.
who randomly do an AMH test and interpret it on their own through Google may think, oh, my egg reserve is pretty good. My AMH is very high. It's around 4 or 5 or 6. That is a false correlation. So I would say, do not go by your AMHs. Do not go by random concepts. Do make sure, if you have PCOD or PCOS, it's very essential that you meet the gynec maybe on an annual basis, because there are other bigger risks, not just fertility. There is a hyperestrogenic state, and you may be at a higher risk for breast cancer or uterine cancer. So these are some things which we need to look at. And also, it can alter your lipid profile and make you a little more hypercholesterolemic, and as well as increase your tendency to develop diabetes. So this is not to scare anybody with PCOS or PCOD, but I would say be on the lookout for all these things, and do not go by random tests or single tests, because in PCOD we do not go by single tests. We do multi-system tests for your cholesterols, for your sugars, for your insulin resistance, and then your fertility reserve. Definitely, fertility reserve does not go by AMH in PCOS. So it's very essential that you make a definitive timeline for yourself and take things forward.
Right. So I'm one of those people who did AMH randomly.
Yeah.
Just wanted to know, so AMH in itself is not enough, right? There are always follow-up tests that need to be done to understand the quality. But the good thing is that there is an understanding of AMH itself, and it's I feel empowering a lot of women to
Yeah.
understand ourselves and our bodies better. Bringing to the next question was, how forthcoming are men now about getting their fertility? Like, there used to be way more stigma and taboo around infertility when it came to men. So I think we're seeing a drastic change in here.
Yeah. I think absolutely. I must agree to this, because I've been in the conventional fertility treatment systems, and the husband wouldn't be in the picture for the until the fourth or the fifth visit. So this is how it would be in the conventional infertility centers. The woman would be accompanied by her mother or her sister or her mother-in-law, but the husband would never be a part of it. And for all you know, it would be the husband who would have the fertility problem. He would be azoospermic or some concerns. But what is the shift that I notice in these days and at Proactive for Her is, we do have couples walking in, and the male partners are much more, keen. And by the time I'm explaining about the evaluation for the women, the men themselves voluntarily ask, so when should I do my test, doctor? So that's an
Absolutely.
excellent shift, wherein I think men are growing to understand their, role in fertility. And when I give big prescriptions to the women and don't give prescriptions to the men, they're very unhappy. They're like, what should I do, doctor? What should I take? So that's a very good shift that we are seeing these days.
So
Yeah.
I also wanted to understand, because we also got a lot of questions on what's the difference between freezing of eggs and freezing of
Yeah.
embryos.
Yeah, that's a very important question, because both are two different entities, and we need to keep in mind of certain criteria when you're choosing either of them. So first, coming to freezing of eggs, this is an option which women who have not decided upon a partner, or not entered into a marriage or whatever kind of a situation, can choose, because egg freezing has its own limitations. Suppose we get X number of eggs. Suppose I get 10 number of eggs in my egg freezing. when we freeze, we all know that these eggs need to be frozen. They cannot be kept at room temperature. So they need to be frozen for being reused at a later date. They can be reused even after 10 years. But the only thing is when you thaw them, meaning when you bring them back to the room temperature to use or to fertilize with the sperm, that is the time your yield drops down. Like suppose you have 10 eggs, it will only be 7 which are viable. So, egg freezing is not a 100% procedure. It's only going to give you 70% results. So, it's very essential that our initial yield of eggs are more than, 12 or 15, so that we have enough number of eggs stored. And the quality of the eggs is the other concern. So, if we take this decision too late, I mean, we may get 12 or 14 eggs, but they may be, poor quality eggs. Poor quality eggs again do not give you good embryo outcomes. So it's very essential that you make this decision well ahead in time rather than pushing it to a stage where your AMH levels are low, and then you're going in for certain complicated situations like pooling cycles or things like that. So normally you would get 10 to 15 eggs in a single cycle in a stimulated ovary. So that is what we target. But if for some reason already the ovarian aging has happened, so again here the emphasis is the woman may not be above 35. She may still be in her early 30s, but her egg reserve may be compromised. So ovarian aging is different from your chronological aging. So it both need not be the same. So we are seeing large number of women below 30 coming with very low AMH like 0.3 or 0.2, where it's hard for us to believe that yes, this woman has such a poor ovarian reserve. So it's very important you do your baseline ovarian reserve testing through AMH. Like you said, the woman would be empowered and she'll at least be confident that yes, my reserve is good and I can still take decisions. So in egg freezing, so it's very important that you time it right. You do it earlier before your egg reserve is compromised and plan it well ahead. So it's not something that you jump onto overnight. So you have enough time. In fact, the programs that we've started at Proactive for Her, we do give the women 3 to 6 months of prep time, because here the woman doesn't have a partner to share her problems or to share the emotional ups and downs that she's going through. She has to face it single-handed. So it's very essential that she's well prepared. I would say all in all, it would be a 6 months to 1 year process wherein first 3 months are focused at your emotional health and you understand what is going to happen. You correct your deficiencies, correct your hormonal imbalances. And the next 3 months, you're prepping up for your reproductive health and specifically, ovarian cycle tracking, all that is done. And then you go ahead with, the actual procedure. So this can be cut short to 1 or 2 months. We do have women walking in from into our clinic who say that I just have 1 month's time. I'm traveling abroad. I want to do it. So, I mean, for people who are in that situation, I think they're prepared to take it up in that short time. So the mindset is very important. The support system is important. Plan ahead, plan early, get your sessions to counseling and go through the procedure in a well prepared manner is what I would say for egg freezing. But for IVF, on the contrary, it's a different situation. In IVF, if if your egg reserve is good and if the sperm parameters are moderately good as well, I wouldn't say it has to be excellent. So even if we have moderate parameters on both sides, you still have 100% yield. Like suppose I've got 5 embryos and all are good quality embryos. Even if I freeze them for 10 years, I'll still have good 5 embryos. So I can get 2 babies out of the 5 embryos, even in kind of, if you look at that 40%, 30% success rate. So definitely you will be able to have good results.
So
So
now bringing
IVF,
to the next, sorry,
yeah.
I'm so sorry.
Yeah, so IVF is a more, assured outcome for you, though the results are 30 to 40% again. Yeah.
So bringing to the next question. So regarding the egg freezing or freezing of embryos, one, hormonally, how much does it impact a woman? And do you also suggest somebody who's going through, it's an expensive procedure. Do you also suggest somebody to go through counseling? Because I believe Proactive for Her also has counseling sessions available in such a scenario. And so this is kind of something we don't discuss. Like, I have a friend who went through, she became an egg donor for her sister. And she just, got her test done. She went with it. And she was extremely cranky for more than 1.5 months. And she was fighting, and, she was snapping, and she was very irritable because there was no counseling or anything done with that. Her sister flew down and she just went for the donor. So, can you shed some light on this?
Yes, it's very essential to know your emotional bandwidth. I do tell all the women talking to me that, if you know that you're emotionally labile, and each one of us is different. So we all tackle stress and emotions in a different way. So we know that some of us are more vulnerable to these kind of situations. And I think for people with already pre-existing anxiety issues or depression, I think all of these people should take sufficient amount of psychological counseling as well. Or I do suggest them to go in for, I did suggest a proactive for her as well, to introduce a fertility buddy kind of a person who can be receptive to all kinds of conversations. Need not just be about the procedure or the finances. The emotional well-being of the woman is the biggest concern these days, because all said and done, you've gone through the procedure, you have a good set of eggs, but what is the point if it has left a traumatic experience in your mind?
Right.
So that's very important, that you rule out the possibility of emotional trauma, which is a big so, and I big taboo. Women are scared. I don't want to go in for injections. I was traumatized by injections. Many women do tell us, I mean, like, yeah. So
In
are you able to
in
hear me?
Yes, but your screen is frozen.
uh,
Yeah. Frozen again. Can you hear me, Dr. Smitha? Dr. Smitha?
yeah, I guess I
Yeah,
had
you're back.
connectivity issues. Yeah.
Yeah.
So
So, yeah.
I left it off at being emotionally aware of your thresholds, and also having your partner where you can, it need not be your friend, it could be anybody whom you can confide in. It could be a totally new stranger who is ready to listen to you. So it's very essential to have one such partner with you, with whom you can discuss and vent out your emotional concerns. And because what we are doing is giving you a high dose of hormonal injections. So normally you can imagine a woman who already has premenstrual symptoms and syndromes. In these women, just for one egg to ovulate, we are going to have so many symptoms. But in an egg freezing cycle, we're giving such high doses that we are expecting 10 to 15 oocytes. So you can imagine your usual PMS into 10 to the 10 or 15
Ouch.
times. So
I can't
it's going to be
imagine.
quite massive. Right? It's going to be quite massive. So it's very essential. And women think that it's only till the day of the egg pickup that I need to be under rest and take care. So I do tell them, even after the egg pickup, 2 more weeks, you're not going back to work. So you are not going back to work and stressing yourself. You need to take a break, at least for a week or 10 days, and reconnect with yourself, because you need to give your body that amount of time before you jump into your routine education system or work system pressures. So
I
women.
think as women, we are not getting enough of the support, like, because we have such a fast-paced life and women are expected to be everything. Like, we're supposed to be
Exactly.
career women, we're
Exactly.
supposed to be great mothers, we're supposed to be great at taking, care of the house, and we're supposed to just bounce back very quickly. And I don't think we're getting enough and
Yeah.
more. So somewhere
Yeah.
therapy, and I feel that we are anyway spending so much money on something like this, rather
Yeah.
than building a resentment in us, because at the end of the day, it's our bodies which are going through most of it, almost all of it. So we should probably look at therapy alongside before we start the journey.
Therapy alongside, and also give your body that time to get back to normalcy. So many people
Correct.
ask, how many days leave do I need for my procedure? So I say, 2 weeks post procedure, also keep yourself low on your schedules, or try to make some time for yourself, take a break, reconnect. Yeah.
In fact, one of the questions that has come in is exactly that: what is the recovery period for any of these fertility treatments like IVF or IUI? How many days would this require us to be off work and other commitments?
See,
So,
yeah.
yeah,
If it is for IVF, IUI wouldn't need any kind of break from your work, because you can always time your scans, and when you're not working. I think most of the fertility centers are making time for working women, because we do understand that you need to get back to work, or you're coming back from work and they're working extended hours. So that for IUI you do not need major breaks, except for the day of insemination. You may need at least half a day break there. And the second thing is, for IVF, definitely it's a lot more trauma, because every second or third day you're going for scans in the first half of your cycle, plus you're getting injections every other day, a couple of injections, maybe 2 injections at a time. So it's quite a lot to handle. So I would say, I mean, most of them have work from home options. So if you do have work from home options, you could do that. Plus, make sure you work only like 5 days a week, so that you have some breathing time over the weekend, or sometime, to balance it out. And second half of the cycle, once the embryo transfer happens, we tell you have to take a break for at least a week or 10 days till the first beta HCG report comes. Because
okay,
I think it's a lot more than just going and working. It's traveling, mental stress, everything adds up. So when you're going for such a
absolutely.
big procedure, it makes sense to give yourself that much time.
Yeah.
Yeah.
So we are just taking the questions now, Dr. Smitha. One of the first questions that came in was, could you please mention the FDA approved IUI home inseminator that you mentioned in the start?
Yeah, it is. I think you can Google it up. It is called MOSI. It's only in the US, MOSIE.
Oh,
Okay.
it's not
So,
available in
yeah,
India.
in India, it is not so easily available. But I think there's one particular brand which has been endorsed by a doctor, which is coming up. So that
Okay.
can also be, taken in as an option. But I would say do this also under the guidance of your gynec,
Got it.
because, yeah.
Absolutely. So there's another question. Can you also discuss about fertility treatments for vaginismus patients? How does it work for them?
Yeah, for vaginismus, it's a lot more complicated, because there's a psychological element and there's a physical component as well. So I would say you may get pregnant by bypassing the whole system through an IUI, which I just mentioned, like an intrauterine insemination. But give yourself that time. Again, we want to know that, I mean, you conceive through an IUI with vaginismus, which has not been treated or corrected. Then the pregnancy doesn't happen. I mean, the whole process of pregnancy and childbirth wouldn't happen without an internal
It
examination.
was.
At some
Right.
stage we have to do an internal examination. So we see a lot of women in that apprehension of an internal examination, and they'll be like, doctor, I can't handle this. So it becomes a challenge then. So all that I'm trying to say is, correct the problem at the start, and going for a lot of options are available these days. We do have an excellent vaginismus program at Proactive for her, and there's
Oh,
this
lovely.
pelvic floor physiotherapy, a concept which was not identified until lately. Pelvic floor physiotherapy is the cornerstone of women's health, I would say, today. Because you have a delivery, your postpartum, your pelvic floor is compromised. Your menopausal and your hormones are at low, your pelvic floor is compromised. So for everything, I think it's very essential at every stage in life, women need pelvic floor physiotherapists, so that we understand the changes that are happening in our pelvic floor and correct it parallelly. So I think that is the cornerstone of treating vaginismus with pelvic floor physiotherapy. And then tackling it, we've had a lot of success stories. Women have been able to conceive naturally after going through, though the first 3 months is like an uphill, but I would say your results will be excellent. So you will learn to handle your fears, and parenting is all about learning to handle your fears. Because
Way more
every
than
day
that.
is a new challenge. I would say every day is challenge, and I'm sure all of you would agree, because whoever are like parenting, because then you're on a new adventure every day. So I think this kind of prepares you for that. Yes, I'm in charge of my own body. So tomorrow you'll be responsible for another new life on earth. So it
100%.
empowers you totally.
One more question that came in was, a lot of, in fact, questions which came in with the registration were age related. That,
Yeah.
if can I become a mother beyond 35? Can I, conceive? Is it okay to have a child at 37? So these were multiple questions for 35 plus women. Is it okay to have, become pregnant post 35?
The oldest mother I've delivered has been in her 50s, but this was before the regulations were very stringent. I mean, before
Okay.
cutoffs were given. So I would say at any age, it literally doesn't matter. What the woman needs to be prepared is, you need to be prepared that you're going to give yourself that time and your pregnancy, that kind of care, that you can avert any complications. So I've seen women with a bunch of complications, but with the mindset that I can handle this, go on smoothly without a single hiccup. I would be surprised. I would be anticipating complications, problems, but they will be so confident that everything goes literally smooth, even though we have hurdles. But on the contrary, I've had younger women who become mothers who are very, skeptical about things. Then they end up in unforeseen complications. So all that is very important is your mindset. Yes, and the other thing, medically, if you can plan your pregnancy at least somewhere hovering around 35. Before 35 is the ideal situation, but at least, somewhere 35, 36 is still a good bet, as long as you've been checking your fertility reserves, you've been doing your annual checks, you are not, compromised in terms of your hormonal health or diabetes or hypertension or any such complication. I would still say anywhere around 35 is still a comfortable span. So do not be in the panic that I have to deliver before 32, 33. That's just a number. Plan it out, get yourself evaluated annually, correct problems, and even if we have problems, if they're corrected and controlled, that's the most ideal situation. So,
Perfect.
yeah.
And that brings me to the next question about thyroid and pregnancy.
Yes.
A lot of questions about, does thyroid affect pregnancy? What happens if you have hyperthyroidism? So does it cause miscarriages? In
So,
general, if anybody has thyroid issues, can they conceive?
yeah, see, first of all, one thing I would like to bring into light is any woman who is facing a thyroid problem which has been genetic. Suppose her mom or her aunt, somebody were having thyroid issues. So there is some amount of genetic component. Then we know that there could be an autoimmune cause for this. Now, why are we worried when it is autoimmune? Is if there has been such a history, then there is a possibility that there are antibodies not only to the thyroid gland but also to the ovaries. So in
Okay.
these women, we can expect a low ovarian reserve. So anybody with a thyroid history of thyroid abnormalities or family history of thyroid problems, I would say get on to checking your AMH much earlier, from the age of mid 20s, or 25 to 30 is when you have to start checking your AMH, so that you're aware that you're not having these autoantibodies affecting your ovarian reserve. So that is one thing I would like to emphasize. Otherwise, there's nothing much to get apprehensive about having thyroid problems in the women. The most important thing is to continue treatment and not discontinue. People do take treatment for 6 weeks or 12 weeks, and then they're like, "I managed it with my diet and other things." That this is not something which can be accepted with thyroid, because women trying to conceive, we expect lower cutoffs of thyroid TSH levels. You would have seen TSH of 4.5 and below is normal for a normal person. But for somebody who's trying to conceive or who is pregnant, we take cutoff of 2.5 or below. So the cutoff is almost much lower than the normal person. Now, why does this happen? Because babies get their thyroid hormones from the mother in the first 3 months. So it's very essential that the mother is producing good amounts of thyroid hormone, which is required for the overall health. So that is the
Okay.
reason we insist on thyroxine therapy. And the thyroid medication is a category A drug. Category A is the safest level of medication that anybody could take. So I would say do not hesitate from taking your thyroid treatment. In fact, if you do not correct your thyroid deficiency, that is the time the baby can get affected. That is the time you're at a higher risk for miscarriages. So especially in the first trimester. So it's very essential that you treat yourself, correct yourself, and continue treating yourself throughout the course of pregnancy.
And we have a similar question, but this time for pre-diabetic, do they have to worry about conceiving?
Pre-diabetic, yes. I mean, they don't have to worry about conceiving, but what they need to know is keep the HbA1c. HbA1c is the average blood sugar in the last 3 months. Okay.
Right.
So this test needs to be anywhere between, 5.5 and below would be the most ideal. But for somebody who's already a diabetic, we would say at least keep it below 6, 6.5, as low as possible, because anything above 7.5 or higher can increase the risk for congenital abnormalities, like some birth defects in the baby, like cardiac defects. All these defects can come up. So we do not want to put the baby into that situation because of high sugars. So it's always good that you enter at a very controlled blood sugar level, because we know pregnancy as such itself increases your glycemic variations. So your glucose intolerance increases in pregnancy. So you even if you enter with a normal sugar, you know that in the mid trimester you're going to have high sugars. So it's very essential that you overcorrect it and then enter. But do not wait. I do have women who say, my BMI is high, I am waiting for me to lose my weight. But I would say do not go by those norms, because there's never an ideal picture. And we all know how hard it is to lose those extra pounds off. So, but the only thing that I tell women with a higher BMI is, be focused in your mind that in an average woman, I would say 7 to 11 kgs is the normal weight gain in pregnancy. But women with higher BMI, we expect only 1 to 3 kilos in the whole of pregnancy. So I mean, that's the amount of glycemic control or dietary adherence that we expect. And I've had women who have had high BMIs, 120 kilos, 125 kilos, and they've been so stringent on their diet that they've gained only 2 or 3 kilos, but the baby has gained good weight. So this is all that you need to keep in mind, that you can optimize in the given circumstance without you know delaying decisions to a more critical time.
Actually, I'm somebody who actually had gestational diabetes in my third trimester, and I
Yeah,
was kept on a very stringent diet to the
yeah,
extent that I did not even put on probably except the baby, nothing. There was no weight at all. It was so
yeah,
strict. It was so manageable that I did not have to go on insulin.
yeah,
I had
excellent.
managed it just with the diet. So yeah.
That's
One more question. I'm sorry.
Oh, that's exactly what I was saying. So if you're mentally prepared, even a little higher BMI is not a contraindication to pregnancy.
Yeah. So there is one question. I'm not sure how relevant here it would be, but it's the question is how to ensure the baby is free of any deformity.
That's an ongoing process. In fact, just last week I did have one of the mothers who was following up with me deliver, and it's very difficult for us to say 100% everything's going to be fine, because there are certain tests and scans periodically which are being done which can rule out major abnormalities, but there are certain abnormalities which cannot be picked up by scan. Every diagnostic modality has its limitations. We need to understand that most common question is, why wasn't it picked up early? The first question that we face. But that's because, see, the baby is growing from as small as 1 centimeter to the adult, to the baby size like 35-40 centimeters. So what we need to understand is, you can pick up certain things only as the baby grows. And the
Right.
functional aspects, like the intellect of the baby, or the uh, uh, functioning, the psychological functioning or mental functioning of the baby, is something which we cannot decipher. And even, for example, this baby had a single umbilical artery, so these babies are at a higher risk of cardiac and genitourinary problems. But scans cannot pick up all the genitourinary problems, so that is something which is still vague. So I would say science has advanced, but not to the extent that we can tell you it's going to be 100% fine. But as long as the major tests and scans are through like your first trimester screening, NT scan, your anomaly scan, your cardiac echo for the baby. Once you've crossed over the major milestones, I would say your probability of having such a problem is less than 2% or 2 to 5%. So 95% your baby is going to be fine if the routine tests are fine, is what I would say.
So, there's one more question about vaginismus. About after how much time of healing from vaginismus we can try for pregnancy?
I would say right away. Right away. I mean, if you're mentally prepared, the fact that you've healed from vaginismus is itself a big credit, and do not delay it further. Take things forward. There's no time span. I think it's majorly your mindset and your preparedness to handle the pregnancy that's more important.
How expensive is it to freeze your eggs?
Yeah, that's a question which most of the women are worried about.
Yes.
See, it definitely involves a procedure cost, a medication cost, plus a freezing cost. So there are three components. So the medications that we use for any woman varies based on her ovarian reserve. So basically, if she's had very low egg reserve, then we know we have to use high dose medication. We need to use recombinant medication. So this itself increases the cost of medications. On an average, the medications can cost anywhere between 75,000 to 1.5 lakhs based on the ovarian response, like what I mentioned. The procedure per se can cost anywhere around, 1 to 1.5 lakhs again. The egg pickup, and that's the procedure. And the third component which I mentioned was the egg freezing. You know that the eggs have to be frozen continuously till you decide to use them. So most of the IVF labs do give you that first 1 year complimentary freezing and other things. And after that, it's an annual recurring cost anywhere between 30 to 40K based on the lab that you've chosen. So,
Yeah.
but they're not very stringent that it has to be paid this year right now. They give you leeway because they understand that if your oocytes are there, you're going to come back there. So most of the fertility centers give you that flexibility. Some centers are coming up with pay us this much for 3 years and things like that. So it's a recurring cost. What you need to understand is your freezing is something that is recurring every year. So
Right.
you may need to pay between 30 to 50,000 per year based on the IVF center that you choose. So all in all, I should say you must be done anywhere between 3 to 4 lakhs. You should be done if it is a normal reserve patient, or borderline low reserve also can be handled. But for somebody with very low reserve, we do recommend something called as pooling cycles, where we collect eggs over 2 to 3 cycles, 2 to 3 months, and each month is again a different egg pickup procedure. So you go through three such procedures. There the cost soars up exorbitantly. That is why you make this decision much earlier before you end up in that kind of a situation. Yeah.
That also, I wanted to ask you, this is something because I know somebody personally who went through 5 cycles of IVF.
Yeah.
Now, I feel that person is an emotional wreck from whatever I've known her. How many cycles do you recommend at the max? Like, this is it.
See, I mean, average 1 or 2 cycles is 2 cycles is the upper threshold, is what I would say. There are couples who've gone to 3 or 5 cycles, but again, it is to be taken with a pinch of salt. How much of it is affecting your overall health? What are the other options you would want to consider? Because these days, many couples are very clear. If it doesn't happen this way, we do not want to pressurize each other or go for this pregnancy itself. Couples do come up. Again, it's a random. I've had patients who've conceived after 5 cycles of IVF or 7 cycles of IVF, but we still have had couples break down for the first IVF cycle itself. So I would say 2 to 3 cycles
True.
maximum is the average threshold.
This question we have is, could you help us with ways to improve sperm health? If there is no smoking, drinking, and healthy lifestyle and workout being already followed, is there anything else that you can do to improve sperm health?
Yeah, this is where the baseline workup, what I was telling, comes into picture. Like, if there's been B12 or D deficiency, vitamin B12 or vitamin D, I would say please check your B12 and D, correct your deficiencies, because vitamin D has a major role in reproductive health. So I think, and more than 80% of the population is deficient or insufficient. So it's very important to correct your nutritional deficiencies. And the second thing is, if you're working with laptops, or you're wearing tight jeans, it's very essential that you get done with these and find alternative options, or wear loose fitting clothes, or keep your laptop away from you and then work on it. These measures have to be followed. Avoid hot showers. These may sound very basic, but then they're very
Yeah.
essential.
I
Yeah.
used to
So
think they're a myth, to be honest.
yeah, but these do make a dramatic difference. We've seen post COVID, especially men post COVID, their fertility rates have been really bad. COVID has left a bigger impact on male fertility. So these, plus I would recommend antioxidants. Like we do get a lot of antioxidant sachets. So I would say men to take them in, because all said and done, the food we eat, the environment that we live in has a lot of contamination, pollution, and heavy metal toxicity. We all know about that. So it is very essential that antioxidants are taken in good numbers.
Right.
Yeah.
So we just take two more questions before we call it a day. This one is, could you guide how to time the cycle? I know again it's a basic question, but I feel a lot of us don't know. So is it
Yeah.
from first day of period or the last day? What's the ideal time window?
Recently, on this note, I had a couple who came to me and they were like, we've been trying from 3 to 6 months, nothing much is happening, and things like that. So the basic error that she did in her app was she was calculating from the day five, fifth day of her period, as the day her period ended, as the day one. So that's lost the window, because the egg is alive only for 24 hours. So, and we calculate the day of your onset of your period as the day one. So
Okay.
start counting from the day of your onset of the period. If you've had spotting for 2 or 3 days before your period, count the day that you had the flow start. So that
The
is day
flow.
one,
Okay, not the spotting.
not the spotting. So that is the day one of your cycle, and that is how you need to start counting your cycle. So that is very essential. And we know that in a 28-day cycle, your ovulation can happen somewhere between the 13th to the 15th day on a rough scale. So that is the reason why I included the basic assessment to have a follicular scan, where in you do a scan around the 13th or 14th day to know when exactly you ovulate. So then you know roughly that every month, roughly around that time, you're going to ovulate. So you can time your intercourse, and you know that sperms are alive for 3 days and egg is alive only for 1 day. So you can cluster your contact period from the, suppose you're ovulating on 13th day, 12th day, 13th day, and 14th day is when you time your intercourse. So you know that the sperms are alive, so they can cover up for the additional overlap on the times.
Also, probably just have, fun while having sex rather than making it so mechanical.
Absolutely, absolutely.
One more question we have is, this is again, circling back to the first thing that we discussed, but I think we can also do a wrap up with this because it says, what are the basic tests before pregnancy? And one
Again,
more question they have regarding the previous one we were discussing, how accurate are ovulation strips to check the ovulation?
again, there's a big bandwidth of the kind of strips that are available in the market, but most of the strips are reasonably reliable. But I've had patients who read a positive strip on 2 or 3 days consecutively. So that itself shows us that you cannot totally bank on the strips. When you do not have any other option, I would say bank on the strips, because if you have the option to do a scan, that is a direct evidence of you ovulating. So rather than betting on the strips, I would say go in for the scan, because in India, healthcare is very accessible. So I would say
Correct.
just drop in for a scan and get your scan done. That's 100% foolproof. So, but if you are not in a situation where you can go, definitely you can use ovulation strips, and they're reasonably accurate. I would say 70%, not more. Yeah.
Otherwise, apps usually do the job of telling you, as per
Yeah.
the cycle, if you put the correct dates.
Yes, you have to put the correct dates and make sure you're not having PCOS or PCOD. Yeah.
Correct. So, like I said, like circling back to that question again, what are the basic tests one
Yeah.
needs to do before planning a pregnancy?
Yeah. So we're talking about before planning a pregnancy here. So we would emphasize more on complete blood counts to look at your hemoglobin, your thyroid tests, baseline thyroid tests, to make sure you're not in a thyroid deficient state, because we just discussed why it's important to correct your thyroid deficiency during pregnancy. Third thing is your sugars, definitely. We need to look at your HbA1c, make sure it's below 5.7 for you to go ahead with pregnancy. So these are the basic hormone workups which we routinely do, and a urine routine definitely. And these days, I would also emphasize on a serum creatinine, because we are seeing more number of women come up with, renal impairment and renal failure because of high protein diets, or, gym supplements which are taken, or weight loss supplements which are taken without proper guidance. So we are seeing women with high creatinine suddenly in pregnancy, and we are wondering what's happened. So it's always
Right.
good to do a creatinine as well. And I mean, these days you don't really need to worry. If you book a package, you have A to Z of the tests coming in. So that's a good thing. And apart from these, the routine virological markers like HIV, HBs, AG, HCV, and VDRL, these are 4 infective screens that we recommend for any woman planning to get pregnant. Yeah.
Do you suggest any supplements that a person should start taking? Say, for example, I'm planning my pregnancy. Do you suggest supplements? Do you only suggest it that once you visit the gynecologist, that's when you start?
I was just looking for what is my supplement. Oh, yeah. So I'm a big believer of this. So please keep fish oil. It's always by my bedside. So pop it in. Fish oil is very essential if you're not very tabooed about its origin from the fish. I would say because it has all the fat soluble vitamins A, D, E, and K, which is grossly deficient in our diets. And it is essential for your mucosal health, for your skin health, for your reproductive health, and for everything. So I would say take some fish oil supplements. Any amount I emphasize is underrating it. So I would say please take into this. Also, folic acid supplements, as we know, preconceptionally are very important. Make sure you start it 2 months prior to planning your pregnancy. So, and if you're B12 deficient, you need to put yourself on B12 supplements at least 2 to 3 months every year. So, because this is a recurring deficiency. So,
For
you need,
vegetarian, especially.
but yes, yes. So these are the basic supplements that I would say. Beyond this, any zinc-based multivitamins, if you think you're prone to infections more often, then I would say take the zinc-based multivitamins.
In fact, as we were discussing, Dr. Smitha, before this call also, that ideally one should visit a gynecologist once a year as a woman, irrespective whether you're planning your pregnancy or not, just for your peace of mind to say everything is okay.
Yes.
Is that right?
Yeah, I do have women just calling me, doc, I just want to meet you once. I mean, they just want to come talk, vent out their feelings. I mean, it may not be a gynec consult also. It may just be, I mean, gynecs are, I mean, thanks to spaces like Proactive for Her, we are connecting with women on a more personal note. I mean, I
Right.
sit in a lot of other places, but I do not find myself connecting with people the way I do connect, because the space also needs to be empowering for both the doctor and the patient to bridge the barrier. So I would say drop in, have that conversation, impromptu conversation with your gynec. That helps you build a rapport with her, and you both know each other, and then we know what your priorities are, and we kind of are preparing you for that. So I think that's very essential that you meet your gynec on a regular note. I mean, I do get people saying not all gynecs are friendly, all of them are like, few of them are traumatic and all that. But I would say do trial and error, meet a few gynecs, see whom you can connect with, and then nothing stops you from meeting her again.
In fact, Proactive for Her offers a judgment-free space where you can just even have virtual sessions. You do not need to visit the clinic. Just have a virtual session, talk to your gynecologist. This I'm saying as a 43-year-old woman, a mother of almost a 17-year-old now, that meeting a gynecologist and building a rapport, like you said, is so essential just for your peace of mind, to feel safe, and generally to know yourself and your body better.
Absolutely.
So with this, thank you for joining us, Dr. Smitha, and it's been a very, very valuable discussion. So yeah, early intervention and understanding your opinion is the key. So thank you for sharing your expertise. Thank you so much.
Yeah, same here, Anupriya. I think we all had a great interaction, and I would love to hear from women that hopefully that we've kind of been helpful. I mean, it was too much of information, but then I hope some amount of it has helped people understand how to prioritize things and take things forward.
Thank you so much.
All right. Bye-bye. Bye.